Good morning, everyone. It's a pleasure to be here, and thank you to Dr. Lloyd Verma for inviting me to this conference. As Ritesh said, my name is Sanjay Choudhary. I'm one of the consultants in an area called Derbyshire, which is in the middle part of the United Kingdom. And I'm also the clinical lead for the screening program associated with diabetic eye disease. This is a national screening program which was started in 2005-2006. And it goes along with other screening programs which that country has, for example, breast carcinoma and aortic aneurysm screening programs. So what I wanted to do today was just familiarize you, give you an overview of how the screening program is done in the UK, and maybe, although it may not be very relevant to you here, but maybe you can pick up some key points from that and use it here in your practice as well. Derbyshire is a county in UK, and the current program size for Derbyshire, the current population of diabetics is 59,322. As Dr. Ritesh said, overall, I think the incidence of diabetes is probably slightly higher in India compared to some of the European countries, but still it is a problem which is getting bigger and bigger as the years go by. And I think screening for diabetes is one of the most important aspects of trying to reduce the incidence of the final blindness which is associated with diabetic retinopathy. And as you are probably aware, in the Western world, diabetic retinopathy is the commonest cause of blindness in the working age population. Obviously in the over 50s it's macular degeneration. So it is a big problem, and we screened around 42,000 patients last year. This is a busy slide. I'll just explain it to you. Basically, in the National Health Service, all the patients are registered with the GP. So the main data for the diabetics that comes from the general practitioner, and all the newly diagnosed patients as well as the existing patients, they are basically transferred electronically to the diabetic eye screening program. So every month we get an update of patients who have been newly diagnosed as a diabetic, and the data is transferred electronically to the screening program, where within 3 months of the first diagnosis of the patient, we send them an invitation letter to come for screening. The reason we have these monthly updates is obviously because some patients are dying, some patients are leaving the area, some patients are going elsewhere. So we have a monthly update, and obviously all the newly diagnosed patients come into the system as well. So what happens on the screening visit? It's quite straightforward. The patients come in, they have their visual acuity checked, they also have the dilating drops put in by the healthcare assistant, then the fundus photograph is taken. And basically, under me I have a team of around 6 to 7 screeners who are also graders, and there is a system which I'll discuss briefly. There is a system how these are not doctors, these are just simple graders and photographers, but they have to pass certain modules in ophthalmology, and they have to regularly uptake certain gradings in a year. For example, every screener and grader has to take 1,000 gradings per year to make sure that they are competent. So basically the screeners, graders, they take photographs and then they grade the image as well, which is called the primary grading. And we have fixed cameras in fixed sites in the hospital, but we also have outreach cameras. So patients, because it's a large geographical area, patients find it difficult to come to the hospital. So we take the cameras to them, and it goes into the community, and the patients get an appointment there, and the photographs are taken there. They are transferred electronically into the system, and then we grade them. So the grading for retinopathy is kept very simple. The R0 grade means there is no retinopathy. R1 is background, and I don't want to go into the details of what a background retinopathy is. R2 is where you have features of ischemia, so the intraretinal microvascular abnormalities and other features of ischemic retinopathy. And R3A is where you have active proliferative disease. R3S is where you have actually had proliferative disease in the past, and that has been treated by laser and is stable. So that's the grading for retinopathy, and we have a separate grading for maculopathy, where M0 is there is no maculopathy present, and M1 there are three different criteria, and you have to remember this M1 does not necessarily mean clinically significant macular edema. This is purely from a grading point of view for the screeners. And M1 is either if there is an exudate within 1 disc diameter of the fovea, or cercinate exudate within the temporal arcades, where the diameter of the cercinate is equivalent to, as in the clinical ETDRS definition, or if there is a microaneurysm or a hemorrhage within 1 disc diameters of the fovea with a visual acuity of less than 612 or equal to 612. We also have a grading for photocoagulation, so P0 means no laser and P1 means that laser treatment has been given. So the range of grading, as you can see from here, can vary from R0, M0, P0, where there is no evidence of any diabetic retinopathy. The patient has not had any treatment, obviously, and these patients are automatically called for screening back in 12 months' time. So they just come back in 12 months' time, they have photographs taken again, and depending on what is found, then obviously the screening interval varies from there. The most active diabetic retinopathy could be the R3A, which is active proliferative disease with macular edema and no previous treatment, or you could have the stable treated proliferative disease with no macular edema and previous evidence of previous laser treatment. So once the photographs are done, then those photographs undergo a primary grading, and this is done by the graders who have also taken the photographs. And depending on what happens to the primary grading, if there is no evidence of any pathology, then as I said, they are called for the annual recall. If there is evidence of background disease, then again, they are again called for annual recall. However, 10% of those primary or background diabetic retinopathy patients, they are secondary graded as well, just to have the quality control. So 10% of those goes into the secondary grading, where different grader grades that same photographs. If the primary and the secondary, they both agree that yes, it is a background diabetic retinopathy, then obviously that goes into annual. If there is a difference of opinion between primary and secondary, then it comes to me as the arbitration grader. So I then look at that image and I grade it accordingly, and I send it for either annual recall or call it to the hospital. There are cases where the graders have said that it is either a R2 or it is M1, and then it comes to me as well in a separate queue, which is called referral outcome grading, the ROG, which you see below. And then I do the referral outcome, and if it is a disease which requires treatment, then I bring it into the ophthalmic clinic. So one of the basic ideas of this whole screening program, apart from trying to pick up the disease early, was also to reduce the burden on the eye clinics and only appropriately refer patients to the eye clinic who need actually treatment. The ones who just need monitoring and screening, they are kept out of the eye clinic and kept into the screening system. This is a separate category of clinic which I have established, and it's obviously running in other places as well. It's called VOPDR clinic, which is virtual ophthalmic digital retinopathy clinic. And basically this is for M1s, because as you could see from the grading for M1, vast majority of those patients may not have clinically significant macular edema and therefore may not require any treatment. But before we had this kind of a surveillance clinic, which is kept in the screening program separate from the eye clinics, we had to bring all these patients into the hospital for examining them, maybe doing an OCT if necessary, and then making a decision whether the patient requires laser or intravitreal injections. So for these three category of patients, all the M1 patients who've been diagnosed on the screening as M1 because of these exudates or whatever is present, all the pregnant patients, because I think we do have somebody talking about how pregnancy affects diabetes, and we have a protocol that if somebody has a history of diabetes previously, then we screen them quite frequently, because obviously the diabetes can advance in pregnancy more quickly than it would otherwise. So, and all these stable treated R3s, because they may develop new vessels, and then if we pick them up early, then we can do some top-up pan-retinal photocoagulation. So basically this clinic, once I see a patient who has been diagnosed with M1 in the screening program, these patients come into the virtual OPDR clinic, where they again have photographs taken, but they also have an OCT. And if there is no macular edema on OCT, then I keep them in this clinic. If they develop macular edema on OCT, then we bring them into the clinic for treatment. Patients with cataracts, again, or any kind of media opacity, even astrohyalosis, there is a problem in screening because obviously we can't take decent photographs to assess the diabetic retinopathy. So they come into a separate surveillance clinic, which is called a slit lamp biomicroscopic clinic, where we have a doctor actually seeing these patients. If the patient has cataract which is affecting the vision, the patient wants surgery, then we transfer them into the cataract clinic. But if the patient's vision is decent, it's just that because of media opacity we can't take photographs, then we keep them in this surveillance clinic and assess their diabetic retinopathy through the slit lamp. This is a typical screenshot of the cues that I get. Now, as you can see, the top one, the arbitration. Do you have a mouse? So do you have a laser pointer? No. Thank you. Yeah, so arbitration is where the primary and the secondary graders have given different gates, and they come into the arbitration queue, and then I look at them and make a decision there. These are the queues for patients who are already in the hospitalized system. So you can see there's quite a few patients who are in the hospital, and obviously they are not screened, but we have a system, electronic system, where in every visit, after every visit, we send electronic information to the screening program with the grades so that it can be fed into the system, and the screening program is aware that these patients do not require annual screening. Primary, secondary gradings, as I mentioned, at the VOPDR clinic, which I have just mentioned to you, that's the primary digital surveillance. These are mainly composed of M1 patients. This is a referral outcome, so patients who have been seen by the primary grader, secondary grader, and they have both agreed that this particular patient has got a disease which requires to be assessed. Then it comes into my queue, in the ROG queue, and I look at that and make a decision on that. And the slit lamp queue is for the patients who cannot be assessed via photographs, and therefore they are seen by a doctor. All the patients who are screened, there are electronic letters which are sent out to all the stakeholders. So the letter copy goes to the patient, GP, the ophthalmologist, and the diabetologist as well. What I also do is because what we sometimes tend to forget is that, it's all related to diabetes, and if the diabetes is not controlled, no matter what you do to the diabetic retinopathy, it will keep progressing. So we have joint clinics with diabetologists once in a month, which basically where I bring in patients who are under the care of the general practitioner, but the diabetes is not very well controlled, and therefore they have diabetic retinopathy. So we sit together as ophthalmologist and diabetologist, and the patient comes in, and we try to manage the diabetes better as well. So basically, just to conclude, it's a highly complex triage pathways to maintain a very sound fail-safe. We do have a fail-safe officer separately who looks after in case we have missed any patients. The patient images can be viewed up to 4 healthcare professionals at one time. There is a fast-track system for urgent cases. For example, if I see any R3 which has been graded, if the screeners grade R3, they send the photographs to me on the same day. I look at it on the same day, print out a letter, and bring it directly into the laser clinic, because it's quite obvious on the photograph that the patient requires a PRP. So within 3 weeks of diagnosis of proliferative disease, we apply the first session of pan-retinal photocoagulation to that patient. The patient history is mapped and referenced by data and photographs. So obviously, as long as the patient keeps coming, we have records of all their visits. We have very well qualified and well-trained staff, and basically one of the ways we maintain the quality control is by having what we call online test and training, where the national committee sets 20 images with different stages of diabetic retinopathy, which all the screeners and graders and ophthalmologists have to access electronically, and then you look at them, and it's a feature-based diagnosis. So all the software that we have, you do not require to put in a grade, as you just require to tick the features which are present, for example, microaneurysms or whatever, and based on the features you have picked up, the disease is graded by the software automatically. So basically, this online photos, online digital pictures we see, and we grade them, and it scores us, and you have to require a certain score to pass that test, and that's done every month. So every person who is involved in the screening has to do that test every month, and then I, as the clinical lead, sit down with the screeners and grader once every 3-4 months, look at their previous history of online tests and training, and if there is any deficiency, then I sit with them and train them on that basis. This is obviously a part of the national screening program, so it's peer-reviewed and regularly assessed by 19 national standards and 3 key performance indicators. So basically, just to see how it has made a difference, I think the program is still quite young because it was started around 2005. But I said in my earlier comments that diabetic retinopathy is the commonest cause of blindness in the working age population. Recent evidence in the United Kingdom now suggests that it may be the second most important cause of blindness because it has been overtaken by the hereditary retinal disease. So it does give us an idea that maybe the screening program in the long term will make an impact on reducing the blindness, incidence of blindness due to diabetes. Thank you very much.